Uh, Hello everybody, Roshtambash. We start another topic regarding the urology. I hope that all you will be safe, inshallah. Postoperative emergency urological surgery. It's a very important and practical topic. Usually this is any operation. Usually any operations has got its own complication from the simplest to the more major. So with almost all operations, surgical procedures, it's important to be aware that complication may happen or may occur. So we have to prepare for it. We should be aware of that. We should think about that. We should suspect in every case that there may be some complication. We have to recognize quickly. Why? Because you have to deal with them appropriately. Otherwise, if you are not to think about it, you don't get the complication as early as possible. There will be a bad sequelae of that complications. So this complication may happen during procedures from day case in simple cases, to life-saving procedure, and it means to the major procedures. It may happen during the stay of the patient after the operation or after discharge to home. We should always take the history whenever you face a case of complications postoperatively, whatever the complication is. The cornerstone of diagnosis and early management is you should always observe the patient, examine, take a history of the patient, what was the cause of the operation, examine the patient thoroughly, read the operative notes carefully. You should read the operative notes carefully, and you should always assess what estimated blood loss was, irrigation, if there is any irrigation fluid, any final achievement regarding hemostasis, or any extra events that has happened during the operation has been fixed in the operative notes. So you should read all this. Why? You get benefit of that. If you, for example, if you have got a case of PCL and during the operation they face a bleeding and they wait for a while the bleeding to stop, so you suspect that there may be a bleeders and has stopped during the operation and reopen again after the operation or post-operatively. And vice versa, when there is a PCL, they didn't complete the operation because of some injury to the kidney or some blood loss or some other complications, probably medical, during the operation that anesthetist had advised the surgeon to stop the operation. Or anything happened during the operation that make the operations procedure incomplete. So the initial management is always, to resuscitate the patients according to the ABCDE. You all know this. So this is an ABCD. You examine the patient, take a history while that you are examining, and take the history, you resuscitate the patient, you give intravenous fluid, you give analgesia, oxygen, and so on. In post-operative emergencies, in inpatient, it means those who have got complication with the operation, still the patient in the ward or in the hospital. Bleeding is on the top. This may be seen in urology, it may be seen in stone surgery. For example, in John surgery, it may be seen in thyroid surgery. Post-operative hematoma and pressing on the trachea and causing dyspnea. In this case, we have an operation, a PCNL. A stone has been taken out through the skin, and after that the surgeon will put a nephrostomy tube and a JJ stent, and most of them also they put a catheter inside. They will tell you that the back is full of blood, so you resuscitate the patient. You should look for the patient as a patient carefully. All the vital signs should fix, and then you start the resuscitation as early as possible. So stone surgery, taking out some stones from the kidney through the skin, a JJ stent and nephrostomy left, ureteroscopic stone fragmentation, and other procedures that it may end with hematuria, although the possibility is much less of that, or after extracorporeal shegolithropsy. I have seen cases of hematoma, big hematoma after Ismail, and even sometimes other complication of Ismail, to remind you, is intra or nearby structure. For example, even pneumonia has been recorded, or injury to the lung, it means, or injury to the spleen, injury to surrounding structure, has been also reported during as well. Because a shock wave, it causes injury to the organs. So in case of shock wave, probably when it is especially energy is increased, it will cause destructions of kidney tissue and by bleeding. During urology, most of cases have got some self-limiting bleeding. It lasts less than 24 hours. It's a mild bleeding, because you are dealing with a very delicate strictures. The mucosa is very delicate, so, but it's much higher in PCNR than in the other procedures, especially if the surgeon. There are a lot of points regarding why bleeding happens in some PCNL, because probably in the higher pole is much dangerous than their lower pole because of the blood supply of the kidney, and the operative time, as has been explained in the previous operation, the number of the stone, the procedures, the length of the procedure, all these will contribute to the degree of the bleeding post-operatively regarding PCNL. And you should always suspect, whenever you have got a case of an anticoagulant therapy, even if you have stopped the anticoagulant therapy before operations, or in hemodynamically unstable patient, cases with some heart diseases or chest probably. So in these cases, you should always be aware more than the other case. Management, operative details, you look for as I mentioned, assess fluid volume status, whether the patient, it means vital sign, whether he has been given necessary fluid during the operation or post-operatively. Full examination, monitoring vital signs, pulse, blood pressure, temperature. This respiratory is very important as well, because the patient have dyspnea. And you should look for urine bags of the nephrostomy and urine bag of the catheter, urethral catheter. In severe cases, when you see that after resuscitation, the patient have got severe bleeding, he has got clot inside the bladder or clot inside the nephrostomy, you contact the radiology. You should do, as it has been mentioned in emergency urology, we should arrange for urgent CT angiography, and we should have all facilities to do angioembolization if we find an offending vessels or a segmental artery which has been injured during puncture of the kidney. Monitoring them as usual, and then you may need to increase the irrigation. For example, after 2RP the patient has got bleeding, you should look at these points, look at the operating notes, increase the balloon if it's decreased, retract the balloon to press on the bladder neck, and then increase the irrigation fluid, monitor the vital sign. Even the patient needs blood, after you send urgently for hemoglobin, and then prepare blood for the patient. If all this measure failed, but still the patient has got pain and retention and the catheter is not working, you have to take the patient again to the operating theater. After preparing the blood, you tell the anesthetist, you tell the operating theater, you go inside, you evacuate by means of Tommy syringe, you evacuate all the blood, wash up the bladder, go inside, see the bladder, see the prostatic bed. If there is any bleeder, you stop it. So after this TURBT or TURP, the bladder tumor, we have still, after such operation, there is another emergency. The nurse call you, doctor, the patient who has been operated on for TURP, the catheter has fallen. What can we do? The patient is unable to urinate. So what are we going to do? The catheter is out. This may happen hours after surgery or to few days. It may happen during the 0 time, first post-operative, second, and up to 5 days in case of TURP, or 7 days in case of open or radical prostatectomy in case of 7 days. So during this period is critical according to the type of the operation, what we'll do. So Causes may include catheter malfunction. Sometimes the catheter, always examine the catheter with dysfunction, or the balloon will deflate by itself automatically. So in this case, you'll be aware always about that complication. Or the patient, or during transfer of the patient from the ward, from the operation to the ward, when they are transferring the patient, there's somebody, the catheter inadvertently has been taken out by pulling of the patient, attendant, or the servant, or any others, or the dresser probably themselves, regarding putting the patient on the bed during transfer. If happened during few hours after 2RP, you should return back the catheter by senior house officer, very gentle, try to it. If not, as I mentioned before, you should try CODI or bi-CODI, and then if not, you have to tell your senior or senior house officer to return back the catheter. It should be 3 ways, and then you start the irrigation again. This should be done as early as possible because the clot will accumulate in the bladder, and it causes retention and pain. If after, for example, you have done a 2RP and your senior said we will remove the catheter after 3 days or 4 days, and in the second day the catheter has dislodged and come out, so you should observe closely. You should take a history. What was the irrigation? And you are daily coming, and you see if the irrigation during second day or third days were almost the very decrease in the volume of irrigations, and the urine is clear. So probably observe and see the patient most of the time is able to urinate, and there is no need to return the catheter back to the bladder. But in case of radical prostatectomy, when you suture the bladder neck to the urethra, in these cases, the catheter should be back to the bladder by means of the senior through a flexible cystoscope. You push a guide wire, you see the anastomotic side in order to prevent the disruption by mistrial of catheterization, and then you put a catheter. Once happened to me, and we put under flexible cystoscope, we push a guide wire, and then we were able to put the catheter in again. Other complication, which is probably most common than the other, is TUR syndrome, which is called dilutional hyponatremia. It means there will be hyponatremia. In electrolyte disturbance, in case of 2RP, on the top is sodium. Sodium will decrease because of dilution, because of the absorption of a lot of fluid to the circulation. Dilutional hyponatremia is secondary to absorption of large volume of irrigant fluid. Previously, we used distilled water. Now, glycine we use glycine. In cases of bipolar TURP, you use normal saline. Although it happens in that, but the rate is, or the incidence is very little when you use normal saline in case of bipolar. It can happen in bladder, a large bladder tumor, or in case of renal surgery. It can happen during the PCNL, especially if there is extravasation of fluid. When you are doing a puncture and your procedure is prolonged, there will be absorptions during this period, and veins has opened, your puncture is big, your implant is big, or there may be sometimes unrecognized injury to the pelvis during the puncture through and through, and there will be extravasation to the outside, absorption of all this fluid to the circulation, and cause dilutional hyponatremia. As I said, in long procedure, in case of significant bleeding, because whenever you have significant bleeding, it means there is a big veins has been opened, and there is possibility that due to pressure of the water, the fluid go inside the circulation. Signs and symptoms: hypertension, bradycardia, the patient start to have nausea, vomiting, confusion, and visual disturbance. You should send the blood serum electrolyte, sodium, potassium, and then for hemoglobin as well. Initial management: fluid restriction. Check renal function, blood urea electrolyte. Management should be in intensive care unit. Fluid balance is very, very important. vital sign, correction of hyponatremia. If it is, for example, below 125 milliequivalent per liter, the hyponatremia should be corrected by giving hypertonic saline 3% or sometimes furosemide. So you should be aware of that. Anuria and oliguria. Postoperatively, the patient starts to have no urine or little. You know, the definition of anuria is less than 100 cc of urine per 24 hour. Oliguria less than 400 ml per 24 hour. It can happen in any type of operation, you know, because probably the fluid is not given or little fluid has been prescribed for the patient, or due to fluid imbalance, or it may be due to renal itself, parenchymal disease, acute parenchymal disease. So it should be in pre-renal. It means little fluid, hypovolemia, whatever the cause, vomiting or little fluid, the patient not taking normal balance of fluid, or renal, cause of renal, the glomerular function. Post-renal, it means there may be an obstruction. So you should differentiate between anuria and obstruction. For example, the patient is anuric, is unable to urinate, or a patient has got retention of urine, old age, probably is not telling you that he has got severe pain, is unable to urinate. The patient, in that case, in obstruction, the bladder is full. But in the case of anuria, you palpate the abdomen, bladder is empty. So regarding urology, we think most about the post-renal cases. Should be reminded if the patient is euvolemic, the patient is normal, skin is good perfusion, the patient has no vomiting, the tongue is not dry, the eye is not sunken, blood pressure is normal, pulse is normal, no response to fluid challenge in these cases. So euvolemic, in this case you should do a fluid challenge. For example, 200 cc with a Lasix or 500 cc in a matter of 1 hour, and then you give a Lasix. Push water with diuretic, and there is no urine output. Sorry. No other factor that suggests the intrinsic renal damage. The kidney is good, polyuria, normal, creatinine is normal, all the things. Okay? So you think about the obstruction. For example, especially the patient has got history of instrumentation or previous urological procedures. Sorry. And obstruction may be at the level of the bladder, lower urinary tract, or at the level of the ureters in the upper urinary tract. For example, yesterday I said a case, stone in the PUJ of the right side and stone in the left uterovesical junction stone. In this case, so you see, still upper on the right side, and the lower ureter is regarded as well as upper urinary tract. So bilateral obstruction by stone. Or it may be clot, stricture, ligation in case of operation. For example, case of gynecological operation, the patient has got bilateral due to probably it happens, and it may happen again because of the difficult procedures or injury to the ureter, bilateral. Post-obstructive dialysis. So in case of obstruction, you should think about upper urinary tract and lower urinary tract. The patient comes to you suffering from anuria, so you roll out the cause and treat accordingly. On the contrary, we have diuresis, post-obstructive diuresis. High urine output exceeding 200 ml per 24 hours. It means more than, polyuria. The definition of polyuria is more than 2,500 ml per 24 hours is called polyuria. So in this, it's more than 200 ml per hour. If you multiply by 24 hours, by 24 hours, yes. So it means 4,000, almost always near 5,000 now. Patients with edema, hypertension, weight gain, and azotemia are most likely to exhibit these conditions. And sometimes it is either probably it is central in case of medical causes, pituitary, ischemia, or space-occupied region, or nephrogenic. The tubule is not functioning, so it causes polyuria. It's called nephrogenic. Diabetes insipidus. It is not responding to antidiuretic hormone. The function of antidiuretic hormone is reabsorption of water in the distal tubule. If this is not functioning, so there will be diuresis. And this happens because there are some disturbances if you have long standing of the kidney. So this is, don't forget, in long standing chronic retention of urine. Always see whether the renal function is good or not, because if the renal function has been disturbed, for example, creatinine is 2 and urea is, for example, 6200, it means this long-standing obstruction has affected the parenchyma of the kidney. So when you relieve the obstruction, there may be post-obstruction diuresis, because the kidney's tubules is unable to concentrate urine because of physiological disturbances of his tubules. So this is another explanation due to physiological release of retained urea, sodium and water, and other factors. Disturbance of, forget about the ANP, disturbance of counter current. So there is disturbance in counter current mechanism. You have got counter current concentrating ability of the kidney. The vasa recta come down around the tubules and go up. So, and then the tubules will come from distal convoluted tubules and collecting tubules in the parenchyma. So all this making a counter current mechanism to regulate fluid and electrolyte in the kidney. There will be disturbance in this mechanism, so there will be the tubular dysfunctions. Management, admission to the hospital. Yes, we should always don't let the patient to go home. Hourly urine output, daily weight, lying and standing blood pressure, because postural hypotension is important. Fluid and electrolyte balance. It takes time. This post-obstructive diuresis sometimes may take even months until the kidney is regained its ability to concentrate urine again. So don't rush. If the urine out in the range of 5,000, 6,000, still you can manage. And always, whenever you face this, you give half of the fluid that patient has already excreted through the kidney. If it is 5,000, you give 2,500 of fluid orally or intravenously. Other complications post-operative is compartment syndrome. This usually happens due to pressure. For example, in left lateral positions, brachial plexus, and if you remember the positions of kidney in previous days of open surgery for stone, open surgery for nephrectomy, open surgery for pyeloplasty. If it's long-standing, the patient's right hand should be elevated, and then there may be some pressures on the hands. I have seen in orthopedic once a time with the compartments of the right hand, palsy of the right hand, especially the ulnar nerve was. It's called neuropraxia. It takes time to regain its function. Ischemia, but this one is not that only the nerve. It's a simple one. It's mild. Pressure on the muscle, pressure on the nerve. It's called pressure symptoms. But compartment, and there is a compartment. It's a muscle and nerve inside the fascia. It's called compartment. Mostly in the lower limb, as I mentioned that. Due to pressure in a closed compartment. Those who have got URP, for example, in a certain position. So you saw an obstruction or a pressure for a long time on the muscles. There may be some necrosis called rhabdomyolysis, and when you relieve the obstruction, this will go into the circulation and cause renal failure. It will obstruct the tubules. This end product of the muscle lysis, or if the treatment delayed. So in this case, you should always think about this diagnosis, prepare for it accordingly. If the simple measure failed, you should do fasciotomy. You should release the pressure in this compartment, especially in the lower limb, as is mentioned, as explained in these figures. Urosepsis, this is a very important complication. It happens in PCNL. It happens in any, even sometimes I have seen this urosepsis during cystoscopy. Those who have got immunocompromised conditions. But it's most commonly happen during procedures which takes time. For example, during long TURP, during radical prostatectomy, during flexible urethral, during PCNL, because of a lot of factors can participate in these situations. For example, you have got a stone surgery, you're doing lithotripsy, and this stone, inside the stone there is bacteria, and you are using fluid. There will be, especially if you are using pressure during flexible to open the ureter and to see the pelvis well, though the bacteria will rush go inside. It is called pilocalicial, or even through the lymphatic, or even through the veins. This bacteria will gain interest into the circulation and cause multiplications and urosepsis. Urosepsis, it means sepsis through the urinary tract. Sorry. It can happen with any form of urological procedures, instrumentation, small removal of the stones. Patients with prosthesis are at risk. Nephrostomy, ureteric stent, Foley catheter, penile prosthesis. Mortality in severe sepsis is still high nowadays. It is important to study urosepsis as a specific sepsis entity. At many aspects, the management may be unique and different from the other. The most common uropathogen is E. coli, as usual, because 80% of uropathogen is due to E. coli. Proteus, Pseudomonas, Serratia, Streptococci, as well as non-bacterial pathogen, various candida, especially immunocompromised. Clinical presentation, you read this, all the clinical presentation of any type of tests. There is no need, you can read all this. Management and effective treatment, resuscitations, and then empirical antibiotic after you have sent blood and urine for cultural acidity. Treatment of sepsis is very important. Supportive therapy, as I said, intravenous fluid, monitoring of the circulation. Antimicrobial therapy should be broad spectrum, and you should have an idea about which bacteria is in your hospital. Accordingly, according to the local type of bacteria, are going to treat the patient by empirical antibiotic broad spectrum. In severe sepsis, you may even give steroids. And thank you very much.